Hello, everyone. My name is Hildegard Greinix. I'm a transplant physician working at the Medical University of Vienna in Austria. And for some years, I've been involved both clinically and in the focus of my research in chronic graft-versus-host disease. So we have an international consortium that consists of members from Europe, the US, Australia, and we try to also include Latin America. And this consortium is meeting on a regular basis under the leadership of the NIH. So we came up with consensus criteria for the diagnosis of chronic graft-versus-host disease, but also for criteria when we call a patient steroid-refractory. As you know, first-line treatment of both acute and chronic graft-versus-host disease is still steroids. For acute GvHD, we usually use 2 milligram per kilogram body weight at the beginning. For chronic GvHD, we start out with 1 milligram per kilogram body weight. And as soon as the patient responds, we try to taper the steroids. But there is patients where we do not see responses. And in that case, excuse me, especially for clinical trials, it is very important that we have an established, accepted definition of steroid refractory. Because during the last years, every institution or every study group had a different definition. And in that case, when they reported data or published data, it was very difficult to compare these results. So in 2018, under the leadership of Elaine Schumanns, this international consortium on GvHD researchers came up with a standard, what we call steroid refractory. And this is the following. For acute GvHD, steroid refractory means if a patient starts out with 2 milligram per kilogram body weight, and after 3 to 5 days, GvHD is getting worse. So, for example, if a patient starts out with skin rash and after 3 to 5 days has severe diarrhea, that is indicating gut involvement, this would clearly be progression of acute GvHD. Or if a patient starts out with mild diarrhea, like 500 milliliter a day, and under steroids, then after, let's say, 3 days, he or she has 2 liters a day. In that case, this would also be worsening and called progression of acute GvHD. Another important area is when patients are under steroids, they stabilize, but GvHD is not gone. And in that case, stable is not an ideal situation, because what we would like to achieve is complete resolution of acute GvHD and also being able to get a patient rid of steroids. So in that case, this would be called steroid-dependent, and would also mean that the patients needs additional treatment. For chronic GvHD, when we start out with 1 milligram per kilogram body weight of steroids, and after 1 to 2 weeks, the GvHD is worsening. For example, a patient starts out with a skin rash on the trunk and has around 50% of body surface area involved. And after 1 to 2 weeks, the whole skin is involved, or another organ, for example, eyes or oral mucosa, is showing signs of GvHD. This would be called progression. And in that case, the patient is steroid refractory. In chronic GvHD, what we usually see is when we start out with steroids at 1 milligram per kilogram body weight, that the patients are usually improving, stabilizing. We can taper steroids. But then after some time, the situation is stable, but we cannot get a patient off steroids. And in that case, it is also important to consider this, because being stable under steroids is not what we'd like to achieve in a given patient. And this is also clinically not meaningful, because what we would like to achieve is getting rid of all symptoms of GvHD and getting the patient off steroids. So if someone is stable, let's say under steroids of 0.5 milligram per kilogram for 1 to 2 months, this is not good enough. So in that case, the treating physician should discuss with the patient sitting in front of him or her what other treatment options are available to get the patient in a situation where we then can taper steroids and the patient gets rid of chronic GvHD. So I think it's important for all patients to know that it's good to initially have an improvement under steroids, but if you have like 1 to 2 months and nothing more is going on and your treating physician is not able to taper the steroids further, you need additional treatment. Because remember, the ultimate goal is that you have no symptoms, no complaints, no clinical signs of chronic GvHD, and that you're off steroids. So in that case, second-line treatment of chronic GvHD should be discussed.